Welcome to Med One Page. My name is Benjamin, and today I'm going to be talking about bone tumors. So when you look at bone tumors, a lot of these need to be important, but a lot of things again are confusing about them, and a lot of facts need to be understood. And I would encourage you to watch this video, try out some trial questions, and then probably watch it a second time so that you try to bring everything together. So when you look at bone tumors, we're going to first understand the biological behavior of bone tumors. We have to try and understand how can we tell this is a benign tumor, this is a malignant tumor. And we have what is referred to as an intermediate, and we shall look at it. It's a special type of tumor, the giant cell tumor. So the benign tumors are well circumscribed, which means they have well-defined borders. They have a narrow transition zone. So when you look at the difference between, or the area between the normal tissue and the mass, you're going to find that the zone that separates those two is very narrow, and they have a sclerotic rim and no soft tissue mass. So most of the time when soft tissue is involved, then we think it is metastatic or malignant tumor. Then when you look at the intermediate, we have the locally aggressive or the rarely metastasizing, and that is the giant cell tumor. And this giant cell tumor most of the time is going to be, it's an intermediate because it's going to be actually aggressive. The history is not going to be long. A few weeks, the patient is having a very bad clinical picture. And sometimes when they metastasize, they go to the lungs. Then we have a malignant tumors, and these ones have poorly defined borders, and most of the time they breach the cortex, they break out of the bone and enter into the soft tissue. So we have soft tissue extension, and then the periosteal reaction is also going to be aggressive because the bone is covered by periosteum, and as that tumor breaches out of bone, as it buds off the bone, it is pushing the periosteum away, and we shall get periosteal reaction. So when we look at the pathophysiology, the tumor growth is going to cause things like bone destruction, and this one is going to occur especially when osteoclasts are activated via the Rankel pathway. This is the most important pathway to remember about bone destruction. But other things like the parathyroid hormone releasing peptide and interleukin-6 also play a role in bone destruction. Then we have reactive bone formation, and as this tumor is forming, it is forming bone. But this bone, before it is mineralized, we call it osteoid. So reactive bone formation is when we form the osteoid matrix, and we shall see certain tumors are going to form the osteoid, some are going to form cartilage, some are going to form different other things, or some are going to cause fibrosis. The periosteal lifting is going to generate characteristic patterns, and these patterns sometimes can give us a clue to what pathology is going on. You see things like the sunbursts, things like the Codman triangle. They are going to come from this periosteal lifting. Then we have marrow replacement. The tumor inside is affecting the bone marrow. Things like anemia, pain are going to come in. And because of the destruction of the integrity or compromising the structure of the bone, we are going to have pathological fracture risk increasing. So if I was to remember about the pathophysiological basis of tumors, or what the tumor is going to bring about, I would remember these 5 things. And when I think about bone destruction, I think about the Rankel pathway. If I think about reactive bone formation, most of the time osteoid, periosteal lifting, the patterns to generate, anemia due to affecting the bone marrow, then pathological fractures are very important presentation of these tumors. So to understand these tumors well, most of the time you have to understand what ages are they occurring. And when you know the ages that they are occurring in, you can be able to come up with good differentials, maybe for examinations or for the patient. So if a patient is young and they are below 10 years, most of the time it's Ewing sarcoma. And even when they are below 5 years, it's rare. And also another good differential to put in mind is leukemia with bone involvement. Then around 10 to 20 years, this is when children hit the growth spurt, or they are growing very fast. And during that period, we have what we call aneurysm metaphysis. So the metaphysis is the second part of the bone. So when you look at the bone, we have the epiphysis up, the metaphysis between the epiphysis, And metaphysis, we have the growth plate. And then after the metaphysis, down we have the diaphysis, which is the shaft of the bone. So what happens is that between 10 to 20 years, the bones are growing. And when these bones are growing, they are forming new bone. So we have osteoblastic activity that increases. Some people call it a noisy metaphysis. So during this time, most of the time, is when we have these osteoid tumors, or tumors that are producing bone occurring. When you look at things like osteosarcoma, when you see osteo, you know that the matrix of that tumor, or what makes up that tumor, is bone. So bone is forming. So osteosarcoma is going to be common during this period between 10 to 20 years when we have the bone growing. Ewing sarcoma, for it we said it occurs mostly in children, and even below 10 years it occurs. Then the osteoid osteoma is one of the benign tumors, and we're going to look at those. So do not worry about understanding, is it benign, is it malignant yet. We are going to look at that. Then you have the osteochondroma, and as the name suggests, we have osteo, which means bone, chondro, which means cartilage. So this tumor is going to occur in areas that have osteo that have bone growing. That's the diaphysis, and that is close to the joint. So when you look at that, the tumor is going to be covered by cartilage because it's arc near the joint. That's how it got the name osteochondroma. Then after 20 to 40 years, most of the time, we have the epiphysis as closed. So most of the time, we do not have bones, we do not have things going to occur. So the giant cell tumor most of the time will affect the epiphysis. The chondroblastoma is basically a tumor that is producing cartilage, and this is the benign tumor. So if it's benign or producing cartilage, it's going to be called chondroblastoma. Then we have fibrous dysplasia, and this is basically the bone matrix. The bone is being replaced by fibrosis. Then about 40 years, most of the time, the most common tumor is chondrosarcoma. So someone with this deposition of cartilage, or the increased production of cartilage, again above the age of 40, most of the time it's going to be a chondrosarcoma. It's going to be metastasis from other disease, things like prostate cancer, things like breast cancer. This is when these things start occurring, and we went on metastases. Then also multiple myeloma, which is one of the common cancers among blacks. And when a multiple myeloma causes a tumor, if it is one tumor, it is called a plasmacytoma. So look at the clinical representation in depth. Most of the time, what happens is that the first symptom is a pain, which is called a gradual deep aching, and some books call it a boring pain. And most of this is going to mean a malignancy. When we have night pain occurring in children, remember, when you have night pain occurring in children, we have the osteoid osteoma. This is a relatively small tumor, but it has what we call a nidus, and this nidus produces prostaglandins. These prostaglandins are what causes the pain, and most of the time when these people take NSAIDs, the pain goes away. If there is activity-related pain, then it is most probably a benign lesion that is near the cortex of the bone. Then when we have a soft tissue mass that is fixed to the bone, we want to think it is a highly suspicious malignant tumor. So sometimes it's going to be a mass that you will feel along the bone, within the soft tissue, but along the bone. And then we have warmth, where you feel a lot of warmth around that area. That is for the giant cell tumor, and this is a very aggressive lesion. Then pathological fractures are common when you have metastases. And when you look at metastases, unfortunately in this video I don't talk about them, but I made a short video giving the different characteristics of different metastatic tumors. Some are going to cause blastic lesions, which means they cause increased formation of bone. Some are going to cause lytic lesions, so they reduce onto bone formation. And some are going to cause both. For example, breast cancer is going to cause both a lytic or blastic lesion. Then prostate cancer is going to cause blastic lesion. It's going to cause formation of new or more bone. And then most of the other tumors are going to cause lytic lesions. So pathological fractures are common. And then sometimes we are to do surgical stabilization, and you have to look at what we call the Muriel score to understand that. And when you have greater than 8 Muriel score, we always think about a prophylactic session. So you can pause the video, check out the mirror score, see the parameters on it. Then we have systemic symptoms, that is fever, anemia. This is common in Ewing sarcoma, lymphoma, and infection. Then we have hypercalcemia, which is going to be common in metastases, and multiple myeloma. Remember multiple myeloma, most of the time we have the crab features, and crab means calcemia, renal failure, anemia, and bone involvement. This is majorly the presentation of myeloma. It would not be fair to include it in this video. It's a very big topic with a lot of things to understand. It's a very important cancer. Maybe we shall make a video for it in the future. So when you're approaching the radiological imaging or X-rays, what we describe it as next step. We want to know the location of a tumor, the size of a tumor, the margins, plus the zone of transition of between the tumor, the matrix that is making up the tumor. Is it osteoid, that is chondroid, that's cartilage, or is it just fibrous tissue? Then we want to reconsider the periosteal reaction, then the soft tissue involvement. So look at the patterns of bone destruction. We have the good geographic, which is going to be well defined. So you have well defined borders, that's sclerotic rim and things like that. Think about a benign tumor. If it appears most eaten, you're thinking about lymphoma or metastasis. So much eaten is like very many edetic lesions within the bone. Like something has been biting away. We think about lymphoma and metastasis. Then if it's permeative, we think about Ewing sarcoma and osteosarcoma, then infections also. Then matrix patterns. If it's osteoid, it appears cloud-like, dense, fluffy like some cotton in the bone, something like that. Then if it's chondroid, it's going to arrange itself in arcs, rings, and popcorn. So on exams, if you see anything like arcs, rings, popcorn on X-ray, just think this is a cartilage tumor. Chondro should come into your mind. Then fibrous is going to appear as ground glass. So a ground glass appearance is going to be influenced by fibrous dysplasia. When we look at the periosteal reaction, it can be solid. The version, when we have a solid periosteal reaction, that is benign, or a fracture that is healing. So there is just basically some little periosteal reaction in these things. Then when we have a lamellated, or they call an onion skin, it is orange pathognomic for Ewing sarcoma. Then the spiculated or the sunburst is going to occur in osteosarcoma. And what causes this is as that osteosarcoma tumor pushes or breaks through the cortex or the cone to pad off. It's lifting the periosteum, and it lifts the periosteum. Sometimes we form this characteristic ray, pattern of rays, which makes the thing look like the sun. So we call that a sunburst appearance. So we have spicules that are going to develop within the periosteum. Then we have the Codman triangle, and this is in aggressive tumors that lift the periosteum off the bone. So when these things lift the periosteum off, we don't have time yet because it's aggressively, or it is within a short period of time. We have just a little osteoid forming along the lifted periosteum, and then we have a Codman triangle, kind of triangle developing between the bone, the periosteum, and where the tumor lifted it up. Then when we start looking at the benign tumors, and in this video they are the ones that I leave in purple, we have the osteoid osteoma. What's important about this tumor is that most of the time it has a nidus. The nidus is close to less than 2 centimeters, and most of the time you can only see this nidus on the CT scan. And if someone tells you they had bone pain occurring at night, most probably a child that is relieved with NSAID, it's going to be this osteoid osteoma. And when we lift the osteoid osteoma, we have a similar tumor to the osteoid osteoma, and that is the one we call the osteoblastoma. Now, the osteoblastoma is going to behave like an osteoid osteoma. The only difference that it is larger and greater than 2 centimeters and more aggressive. And the osteoid osteoma, unlike the osteoblastoma, the osteoid osteoma occurs more in the limbs. The osteoblastoma has a more spine predilection. So if you hear someone having a tumor in the spine, and they're talking about things like that, nidus and stuff, greater than 2 centimeters, you want to think about osteoblastoma. Just like a blast big. So it's bigger than the osteoid osteoma. Then we have the osteochondroma. This one's the most common benign tumor. The important thing is that it is covered with a cartilage cap. And when that cartilage cap is greater than 2 centimeters, most of the time we have suspicion that this could be a malignancy. But what happens is that we have increasing size or pain, and this osteochondroma can be what we call a pedunculated, where it has a stalk attaching it to the bone, or it has it's sessile with no stalk. And most of the time when it has a stalk, this stalk is coming from intramedullary cavity. It's coming from inside the bone, pushing outwards like that. And because of this osteochondroma occurring near joints, because it's where we have cartilage, yes, and cartilage, and it's going to occur during the period when we have bone formation, or so it's around the metaphysis, so near the joint. So what happens is that it can cause a lot of things here. It can cause a bursa formation. Remember, the bursas most of the time they contain the synovial fluid and everything. So as you extend the cartilage, you distort in that structure, a bursa may form. There can be nerve fibers as well as blood vessels passing through that point. They can get compressed, and then because it is messing with the integrity of the bone at that point near the joint, most of the time also pathological fractures can be common. Then we have what we call the chondroblastoma. And as you see in this one, we have chondro, which means cartilage, blastoma, which means formation, or there are blasts that are forming this cartilage. So it mostly affects the joints in young children. And classically, it gives you an epiphyseal lesion. So it's going to occur on the epiphysis or on top of the bone in the next to the joint. And it's going to appear a very, very small lesion, and most of the time it may be missed. So sometimes a bone scan or a sensitography can be done, and it will detect where that tumor cell is, and it's going to affect these joints, cause a lot of pain. Sometimes it causes perilesional edema on MRI, and most of the time it's treated with aggressive curated plus a growth. Then we have the giant cell tumor, and the giant cell tumor is an intermediate grade tumor, and most of the time this one, the history is going to be a bit brief. It's going to behave like a malignant tumor. Within weeks, someone is having a lot of pain in the area. They could even have a fracture already. So most of the time we have osteoplastic giant cells occurring in this. And osteoclasts are the cells that break down bone. So we have osteoclastic giant cell, and it may be locally aggressive. It eats away the bone very, very, very fast. And for it to occur, we have to have a closed epiphysis. So think about 20 years to 40 years after someone has closed the epiphysis, we have now this tumor occurring, and it's going to occur in the epiphysis up. So the growth plate has closed, giant cell tumor now sweeps in. Then it will give what we call a soap and bubble appearance when you see it on X-ray, and it may metastasize to the lung. If it does metastasize, the treatment is extended curated with a high-speed bar, plasfenol and argon beam, and then cement packing is done a lot to try and salvage the integrity of this bone. And denosumab, which is a biologic medication, can be used in difficult cases. Then when we come to the malignant tumors now, the ones that are put in red, the first one is going to be the osteosarcoma, and this one occurs mostly in the distal femur. That's next to the knee joint, the proximal tibia next to the joint, and then it occurs in the proximal humerus, which is up next to the shoulder joint, and the distal radius that is next to the. So you can see where it likes to occur mostly, and it has several subtypes. And you have the confessional type, the telangiectatic, the parosteal. The parosteal basically just occurs on the surface of the bone, and most of the time it's a low-grade tumor. Then you have the periosteal, and then the small cell variant. So what happens in the osteosarcoma is most of the time you have osteoblast producing osteoid. And it's also common in children during the period when you have growth of the bone at the metaphysis. And then Most of the time, these osteoblasts are producing a lot of this because of a P53 or RB mutation, because these P53 are like checkers in the cell cycle. They have to regulate the replication of the cell. So you have RB or P53 mutations. We have uncontrolled proliferation of osteoblasts that are forming bone, and then we end up having an osteosarcoma. And when you're staging, you must exclude lung metastases where it could probably go, and then skip lesions, because if you are going to maybe do an amputation, you may have to consider where one lesion could be below or above the point that you think has the cancer. The treatment, we can use chemotherapy. This tumor sometimes is going to respond to chemotherapy, that is methotrexate, doxorubicin, and cisplatin, and then you do limb salvage surgery, where margins are very critical. You have to make sure you have an narrow node margin with this. Then the next tumor we're going to look at is the Ewing sarcoma, another common sarcoma within children. And this one is some of the most important things you have to remember is the genetic thing, which is the T1122. We have a translocation 11 to 22. Always remember that. Or what we call the Ewing sarcoma, FL1 fusion. This is diagnostic. This is very important to remember for your examinations. Then clinically, we may have systemic features that mimic osteomyelitis, because it's going to occur on the shaft of the bone, and it's occurring in children. So I made a video about osteomyelitis, and it's a common thing among children. Check that video out. So when you look at the labs, the ESR is going to be increased, as well as the LDH in these patients. Then when you do the imaging or the X-ray, you'll see what we call the onion skin periosteal reaction. This is only found in Ewing sarcoma, and we can have a large soft tissue mass that is disproportionate to the bone destruction. So the bone is spared, but the soft tissue mass is big. Then the treatment of Ewing sarcoma, we have multi-agent chemotherapy. That's the VDCIE plus surgery plus radiotherapy. But remember, when you give radiotherapy in a cell that is growing, you can cause DNA damage that again results into other cancers. So secondary malignant risk is high in children who receive this chemotherapy. Then when you look at the next tumors, that is the chondrosarcoma, and this is basically a malignant tumor that's producing cartilage, and it's going to be common in people over 40 years of age. And the cause is going to be pain and progressive growth. Locations are going to be in the pelvis, the shoulder girdle, and the proximal fever. And most of the time, chemotherapy and radiotherapy are inactive, and you have to really go into that joint and do what is called a wide resection, and that is the only curative treatment. So the other important things to know about bone tumors, like the biopsy, what you must know is that it must be always performed after full imaging. You want to do the full imaging, then you do this biopsy, and it is done by only a surgeon who can do the definitive management. If you cannot do the definitive management, do not do the biopsy, and the tract that you use to extract that biopsy must be able to be excised later with the tumor and block together with the tumor. And we prefer doing a core needle biopsy and do the open biopsy when the core needle biopsy is insufficient. And whenever you do biopsy malpractice, there is a risk of limb amputation. Then another thing that is important, now that you're done the video, is that you have to know the location of these tumors. If the tumor is occurring in the epiphysis, most of the time, if the epiphysis is closed, consider a giant cell tumor. If the epiphysis is open, consider a chondroblastoma, which is basically a tumor producing cartilage. Then if the tumor is in the metaphysis, that is the region just below the growth plate, this is the place where we have a lot of bone growth. Think about osteotumors, osteosarcoma, osteochondroma, enchondroma, as well as the non-osteofibroma. And the enchondroma is going to be commonly seen in the hands of patients. Then If the tumor is in the diaphysis, think about Ewing sarcoma, think about lymphoma, think about fibrous dysplasia, as well as an ademantinoma. Then if it's in the flat bones, the pelvis, the scapula, think about a chondrosarcoma. The chondrosarcoma likes the pelvis and the scapula. We've seen that is in people over 40 years of age. Then also Ewing's likes the flat bones, as well as metastases also like the flat bones. Then if it's in the spine, think about hemangioma, think about a plasmacytoma, and think about metastasis. Remember, the benign tumor that likes the spine is the osteoblastoma. Then when you see these signs on examinations or on your x-ray, if it's the sunburst, think about osteosarcoma. Onion skin, think about Ewing sarcoma. Ground glass appearance, think about fibrous tissue, fibrous dysplasia. If it is a soap and bubble, that is pathognomic for the giant cell tumor. If it's rings and arcs, that is the chondroid lesion. There is cartilage there. Consider those cartilage forming tumors. When if it's the nidus, it's only in osteoid osteoma, and it's the tumor associated with prostaglandin, and the relief with inside is almost pathognomic for osteoma. So we've come to the end of this video. We have looked at a lot of things going on. I hope I've tried to make sense of a lot of these things. So make sure to at least try out some questions. If things don't make sense, you watch this video. And we shall meet next time. My name is Benjamin.